Okay, let us begin. So Bula, kia ora, talo ofa, hello, and welcome. My name is Julie Millard, and I am in Warang, Sydney, Australia, on Gadigal land. I'm a mental health nurse, a board director of the World Federation for Mental Health, and the chair of the Oceania Mental Health Webinar Working Group. I welcome you to this important webinar. It is wonderful to see so many people attending, and hopefully, from what I can see already, from different nations across the Pacific region and from other countries. I would like to start by acknowledging the Indigenous peoples of the world. I recognise their ongoing struggle for self-determination, for the right to freely determine their political status and economic development, and to protect their culture, land, and communities. I pay my respect to all elders. I also acknowledge the experience of people living with a mental health condition, emotional distress, or suicidality, and their families, carers, and community groups. Connection, collaboration, compassion, and working together will help to reduce stigma and to build better mental health care globally. I was going to show you some slides about our past webinars, but I've changed my mind now. So I want to start by thanking the volunteer members of the Oceania Webinar Working Group for their hard work in putting this webinar together. Though the OMAC, Oceania Mental Health Advisory Committee, is no longer operational, the connections and the annual webinars continue. Over the last 3 years, we've had webinars around Pacific mental health needs beyond COVID, about mental health workforce in the Pacific region, and about well-being at work, the cultures of support and connection in the Pacific region. Annual webinars for us are an opportunity to showcase the diversity of cultures, the strengths of individuals and nations, and the wide-ranging challenges for people in the region. The webinars seek to recognise the importance of people speaking for themselves, of being heard, of universal human rights, and of the need for sharing and capacity building, and how essential it is to have culturally inclusive services. That brings us to today's webinar. Sorry, a bit dry. I'd now like to introduce Dr. Sheetal Kumar from Fiji, who is the moderator for us today. Dr. Sheetal is a medical doctor with a special interest in psychiatry. After completing postgraduate training, Dr. Sheetal joined the Fiji National University, where she actively engages in teaching, mentoring, and academic development within the medical program. She is passionate about advancing psychiatric education, supporting the next generation of clinicians, and contributing to the growing field of mental health care in the Pacific region. In addition to teaching, Dr. Sheetal maintains a strong interest in clinical practice and research, with a particular focus on the integration of psychiatry into general medical education and the promotion of mental health awareness. Thank you, Sheetal. Over to you.
Thank you, Julie. Good morning, kia ora, Maori, Maloelele, Talofa, and Bula. Thank you, everyone, for joining us today. Our webinar will focus on cultural wisdom, connected care, negotiating crisis and challenge in the Pacific region. This webinar is for 90 minutes and will consist of 4 amazing presentations by learned colleagues. There will be a performance piece and a wrap-up and close. We hope you can stay till the end. Everyone attending today is muted and off camera, but the webinar is being recorded and will be posted to the World Federation for Mental Health website in the news section. If you have any comments or questions, please put them in the chat box. We will try and cover all questions that are in the chat box if we have time. The chat box is located at the bottom of your screen, and there is also a react button, so you can send an emoji. Please put your name and what country you are joining us from in the chat box. While we're doing that, I'm thrilled to introduce our first presenter. Dr. Jian Long of Fiji is a mental health specialist with extensive experience in clinical practice, multidisciplinary research, and global mental health. He is a psychiatrist and holds a PhD in psychiatry and mental health. Dr. Long currently serves as a technical officer for mental health at the Division of Pacific Technical Support within the WHO Western Pacific Regional Office and WHO Representative Office for the South Pacific. The title of Dr. Long's presentation is Strengthen Mental Health Response in Crisis Across the Pacific. Without further ado, Dr. Jian. Thank you.
Thank you very much, Dr. Shita. Yeah, let me share my screen right now. Before everything, just want to make sure is my slides are okay to present right now.
Yes,
Yes,
Dr.
they
Jian,
are.
we can see a slide.
Okay, wonderful. Thank you so much. Thank you, Julie. Thank you, Dr. Shita, for the introduction, for the opening. It is very, I'm feel so privileged to be here this morning to share some information about supporting mental health in Pacific humanitarian emergencies. So what I want to see before everything is that I want to introduce our office because now our office actually is based in Fiji. So Bula from Suva, Fiji. We are actually supporting 21 Pacific Island countries and areas. So if you are interested, feel free to go to our website, which I put into this slide, Division of Pacific Technical Support of WHO Wipro office. Then I think what I want to say is that today I think it's this webinar today actually it's very meaningful because we're approaching this year's Mental Health Day. The theme for this year is access to services, mental health in emergencies. So I think this is very interesting and also timely topic for us to discuss. And I noticed that on the agenda we have different many experts from different parts of the world to share their opinions on this topic. Again, thank you very much for creating such an opportunity for us to discuss on this matter. So what I want to present first is mental health emergencies globally. So from WHO, what we know already is that at this very moment, about 305 million people need humanitarian assistance and protection this year. And an estimated 67 million people with mental disorders are living in conflict, disaster, or displacement settings. Conflicts, disasters, and health emergencies take a heavy toll, as we all know, and with 1 in 5 affected by a mental health condition. But what we need to realize that their needs are not margin. People with mental health conditions in humanitarian settings, including those with pre-existing conditions, receive no care at all. And mental health support in emergencies is not charity and not optional. It is survival, dignity, and also the foundation of recovery. So mental health in emergencies are pivotal for us to consider for WHO as well as other stakeholders think about. Another key message from WHO, what I would like to share this morning is mental health is essential for rebuilding lives because beyond food, water, and shelter, people need mental health support to cope, recover, and rebuild. What we are doing, WHO is doing globally, what I can share with you is that we are supporting mental health in over 40 emergencies today, backed by a global interagency search roster of 6,000 specialists with 15 deployments in just the past 6 months. And a global golden standard for MHPSS response is presented by the MHPSS Minimal Service Package, MHPSS MSP, and can be used by all sectors in all emergencies. And in 2024, the WHO provided life-saving psychotropic medicines to 2.1 million people with severe mental illness in conflict settings like Sudan, Chad, and Ethiopia. And we also helped rebuild systems in Myanmar, Syria, and Lebanon. So what I would like to highlight here is that MHPSS minimal services package is our golden standard for us to develop and also support our member states to enhance their MHPSS capacity. Also, what I would like to highlight here is that MHPSS preparedness has been incorporated into our comprehensive mental health action plan 2013 to 2030. So it has been one of our key targets in our action plan. We set the target as by 2030, 80% of countries will have a system in place for mental health and psychosocial preparedness for emergencies as well as disasters. What I also would like to share with you, everyone here, is that what has been achieved according to the WHO Mental Health Atlas 2024, which has been released just 1 month ago. So what we found and what you can find in this WHO report is that 48% of our member states now integrated MHPSS into preparedness plans. And also 71% of humanitarian emergencies has a functioning multi-sectoral MHPSS coordination mechanism. And the number in 2019 is 48%. And right now, 95% of emergencies deliver MHPSS as part of the response. And 58% of crisis-affected countries have integrated the interagency standing committee MHPSS minimal service package into their response. So even though we achieved so many things, but still we have a lot of challenges and gaps. So the first one is MHPSS coverage and quality still fall short. And the second one is mental health workers and other frontline workers need more protection, supportive supervision, and also time for self-care. And last but not the least, challenges we are facing is country requests for those essential medicines in humanitarian crisis dropped by 96% due to the sudden vanishing of international funds in recent years. From WHO's perspective, what we feel the most urgent thing we need to do is to integrate MHPSS key activities through the health sector, cluster, and sector. So we have so many activities we can possibly do, but what we need, first is a great coordination across and within sectors. In the Pacific, our office based in Fiji the DPS office of WHO, we are already, action with our partners. The first thing what we already achieved that we, in collaboration with Fiji National University, we developed FPA courses and we have already put it online. And what we are trying to do is that also we want to also move these online courses to our Polling, which is which is and a WHO online platform for the Pacific. For we already have like MH Gap and also other online courses available on the platform. Now we are trying to also move this first psychological aid online courses onto this platform. And also we are also conducting some in-person capacity building activities. For example, in September this year, we conducted a MHPSS in-person training in Suva, Fiji, and just to enhance Fiji's capacity to develop and also to implement MHPSS activities in the country. So we obviously we need to do more, but also I think it should be a collective like methods we need to use to enhance our capacity for MHPSS in our region. And I think this today's webinar serves a great opportunity for us to learn each other and to listen to each other and to guide us how we can do a better job for on MHPSS in the Pacific. Thank you very much. And feel free to reach out if you have any other you need any other information and also requests. Thank you very much. Over to you, Dr. Shita.
Thank you, Dr. Jian. We have a question from Soro.
Yes.
Has there been a study whether a one-off or longitudinal study is done for Fiji and or the Pacific on mental health and looking at culturally responsive approaches?
Yes, we just commissioned our office commissioned to situational analyze one on mental health and on one substance use, but we unfortunately we did not really identify any studies or research on using these methods. But we do have some research on mental health as well as substance use in the Pacific. But what we observed from this study, I mean, the commissions, what we found is that evidence base is still quite weak for the Pacific, which we need to further work on, obviously, in collaboration with regional universities and research centers and other stakeholders. Yes, I think we can also share those reports, I mean, commissioned reports. If you have the need, just feel free to reach out to our office and we can share the situational reports with you and you can have a look and also we can discuss how we can further like address the research gap in our region on mental health as well as substance use. Dr.
Thank you, Dr.
Shita.
Jian. Very quickly, we have two more questions. Just very brief responses, please, because we're going to be on time. From Altab, how can these be integrated in workplaces here in Fiji, understanding that a large number of populations are in workforces?
Absolutely, this is such an important like topic. So mental health at workplace is also one of our priorities in the sphere of mental health right now. So what WHO already offered is that we already have a guidance on mental health work at workplace. So I think we offered our guidance to our member states. I think if all the stakeholders can have a look at our guidance and think about how we can adapt our guidance and adapt our suggestions on mental health at workplace, then from there, I think we can develop some initiatives in our countries, in our region. Then from there, I think we can enhance our mental health at workplace, start bit by bit. That's gonna be my very quick reflections on this question. Yeah.
Thank you, Dr. Jian. Last one from Connie. Can you give an example or experience on MHPSS systems to provide ongoing support for chronic climate stresses versus acute climate disasters?
Sure. I'm gonna be very brave in the interest of time. So basically, for example, in Vanuatu last year, so as you can recall that was a big like earthquake. So after that, I think we for really like urgent response, what we provided is that we provided like key messages with our MHPSS minimal service package, and we developed a lot of like key messages delivered to the public. And also for stress management, I think that's a long-term work we already did. That's at WHO, for example, we do have, for example, PM Plus, which is a toolkit which can empower the community to develop self-helping and also stress management like skills. I think that one we already delivered even before the disaster. But also I think that's a capacity we need to build before the disaster. But also I think urgent like responses, for example, message delivering, those kind of things we can do, after the emergency. So those two things we need to do both, but in different stages. Yeah. This is like how we do it, like possibly. Yeah.
Thank you, Dr. Jian. If you could put the link for the guidance into the chat box, please. I'm sure all of our attendees would really appreciate it.
Absolutely. After this presentation, I will put all relevant guidance and also technical reports into the chat. Yeah.
Thank you so much, Dr. Jian, for your presentation on strengthening
Thank you.
mental health response through mental health and psychosocial support. Next up, I'm delighted to introduce our second presenter. Phyllis Tangitu of Aotearoa, New Zealand, is the mana whakahere with Emerge Aotearoa. Phyllis was raised among her whanua in Ngati Awa and Te Arawa and is strongly connected to her whakapapa, whanau, and whanua. Phyllis has extensive experience in working in health, mental health, and Maori health at a local, regional, and national level. Phyllis currently works with Emerge Aotearoa as mana whakahaere and provides leadership to the organization's aspiration to become a tangata tiriti organization, Maori Health and Equity for Maori. Phyllis is a community member for the Mental Health Review Tribunal of New Zealand and a member of platform Te Kaunahere RANZCP, the governance group of Te Tahu Aura Health Quality and Safety Commission, and the Mental Health and Addictions Partnership Group. Phyllis is partner to Wi, Mam to Hui, Te Kahu o Te Rangi, the Hangawari and Tamihana, and Nen to her 7 Makupuna. Phyllis will be presenting on Aotearoa, New Zealand, overview from a Maori mana whenua perspective. Thank you.
We are the color felt in spring. You are the wind. Breathe into me. You inherit me. I inherit you. I am the language you speak to me. As far as the eye could see, everything is changed. Tell me, how can we stand by
Thank you, Julie. Nunui rawa ngā mihi atu ki a koutou, kei noho i tēnei wā tēnā koutou katoa. Very, very warm and respectful greetings to you all from wherever we're sitting in the South Pacific. Nui rawa ngā mihi. Very warm greetings. I always take Stan with me when I go anywhere to do presentations because I think his words are just so important as we navigate this journey, looking at cultural wisdom, connected care, and how we negotiate crisis and challenge across the Pacific region. I've chosen to talk about, thanks Julie, next one. I think my introduction was enough to have to share any more. So wanted to start with this whakatauki, e hara taku toa I te toa takitahi, engari he toa takitini. My strength is not of a single warrior, but that of many, and it emphasizes the collective strength that we have as Māori, and certainly of those of us from Indigenous peoples. And the picture is of the 28th Māori Battalion, and we certainly experienced here in Aotearoa, when our men went off to war, they stayed intact as a unit, as a tight unit group, and they never functioned as single warriors. And I think as we travel journeys where crises occur within our communities and with our people, that's certainly what happens within the Māori world. Thank you, Julie. So on the 25th of March, and I know that we've had a COVID discussion in this forum before, but I wanted to talk a wee bit more about that because of my personal journey when this occurred. So 25th of March 2020 at 11:59 p.m, the country was put into lockdown, and this is New Zealand and I think the world. And what occurred at that time was had a huge impact on our community, particularly Māori. Whoever would have thought that we would have experienced a pandemic? Thanks, Jules. Next one. The communities that we worked in, and I had the opportunity of working for the Emergency Operations Unit, and on the screen this is the top part of the North Island where you've got the swoop. So the mid-central region of the North Island is where we come from, where I come from, and we looked after the people from largely one large town, Rotorua, Taupo and Turangi, heading south, a population of 105,000, of which 35,000 of those were Māori. And I have to say that certainly in Rotorua, 50% of them were below the average sort of income and could have been seen as being vulnerable within the context of having to deal with the crisis. Thanks, Julie. So who are we? I just had to share pictures of all of my grandbabies on the screen there, but we come from Māori across the Rotorua, that region that I shared, but also the wider regions. We have genealogical links with Māori from other areas as well. Thanks, Julie. So we knew that the impact on Māori communities would be significant. There was going to be disproportionate risk and impact due to the inequities that we know we experience within health, housing and income. We had to take those living on the streets off the streets immediately and put them into motel accommodation. And I remember going to work the second day of COVID and stopping in the middle of town, and it was just absolutely quiet. You couldn't even hear birds tweeting in the background. But the next day when I was driving up to work, I remember driving past through one of the lights, because we were the only people on the street with those who were essential workers. And this man came running out of one of the buildings with his sleeping bag tucked under his arm and this old rubbish bag held in one hand, and he waved out to me and he said, "Help, help, fire," or "Help, lady." He said, "I'm lost. I woke up after 2 days and everybody's gone. Has the world ended?" he said to me. And I said to him, "How come you've been asleep for the last 2 days, lad?" And he said that he actually got drunk 2 days before and he just woke up at that moment, and here I am. So I put him in the van, took him back to the hospital where our emergency ops centre was based, and made sure that he was okay. He understood what was going on, and then we located him in one of the hotels. But there was significant risk for our people. There were people with existing health conditions. There are barriers, of course, to accessing services. And because of the mistrust that many Māori had in government-led responses, because of historical breaches and other issues, Māori, we did have to work really hard to reassure Māori that what we were doing at that time was going to be okay. And of course, all of our rituals, our celebrations, and our processes. Tangihanga is when we have deaths in our families. All of those had become, they had to stop. Next one, thanks, Julie. So then one of the things that happened on the third day of COVID lockdown was I received a call from some of the leaders amongst our Māori community, and they said, Phyllis, we've got 140 workers that need to be mobilized to go into the far reaches of our community and identify where people are. And so you help us do that. We have to be essential workers. How can we become that? So over the next day and a half, we held online sessions. We trained people who came from all walks of life. There were lawyers, there were truck drivers, there were people who were integral parts of the community. None of them were working, and we trained them to be frontline workers. And literally gave them a health 101, mental health and addictions 101. You know, what are they looking at when they sort of approach people and places? So they then organized within 24 hours of lockdown, all of the iwi or the Māori groups across our tribal area pulled together $1 million in one bank account to be able to acquire food and other urgent supplies so people could be supported whilst they were in lockdown. It was just incredible. And marae, or our gathering places, began to consider how they could use those venues for places of sanctuary for people who didn't have homes. Next one, thanks, Julie. Some beautiful pictures of that mobilization, but these ones were actually taken further on down the track when they started having testing stations for COVID. Māori communities, Māori providers mobilized the testing and worked very closely with the health system because they knew the people. They took these services out into the communities, and they weren't just based in some of the local or attached to hospitals or local community areas. Next one, thanks, Julie. Yep, so they traveled through the community. What was amazing with their approach, these 150 essential workers from geographic areas, their Māori regions, they didn't just knock on Māori doors, they knocked on everyone's doors. And they did their mini little exams about, you know, how are you feeling? Do you have any health related issues? How's your mental health? Are you feeling okay? Do you understand what's happening? These people were just phenomenal. They got into the heart of communities. They found the most vulnerable, and they were able to bring them back to the center. And they didn't just focus on our people, on Māori. They knocked on everyone's door. Thanks, Julie. Just another example of the beauty of the mobilization of our Māori workforce. Ka pai, Julie. And there, the food distribution, we had donations from many people, but Māori from our iwi groups, they, as I say, they collected $1 million. They weren't quite sure what on earth was needed that time, but, you know, food was often the commodity. But when the team went out and spoke to people in their homes, they asked, what is it that you need? How can we help you? And some of them, you know, some of them didn't even know how to go online to pay their power bill. So many things were sort of brought into that fray. Thanks, Jill. So we call this manaakitanga, or care beyond the clinical realm, but care that's absolutely inclusive of everything. We provided that physical, emotional, and spiritual well-being support. We trained all of them to understand when they might be presented with mental health distress and what that might look like. And certainly, if they did find somebody that might have been in distress from a mental health and or addiction-related perspective, they would come back to us at the centre and get some more expert support and advice. Kai sovereignty, food was hugely required across all of our communities. So food distribution centres became important, and how they were sent out to support the people. And the other part that was incredibly significant during this time was how we enabled people to conduct some of the rituals that we had, like grieving for our dead, and how we could have karakia and other activities online. But the emphasis was always throughout that time of our collective well-being and not just our individualism. Thanks, Julie. So what enabled this from our perspective? It was about us retaining our ability and sovereignty as Māori. We worked within our tribal groupings. We gathered our tribal resources from a physical, emotional, and financial perspective. We put all of that together, and we developed a strategy to help support those most in need. And what was absolutely important was it wasn't just about Māori. It was about all of those people across our community who needed help. Our whakapapa, or our genealogical connections, was hugely important. We had to identify within our tribal groups who the leaders were, because as you can well appreciate that time, some people would listen to some, but not to others. So we had to certainly bring those leaders forward. And the trust and agility of our iwi networks to be able to mobilize was just incredible. We had deep local knowledge from within those communities, and we certainly worked with the people who lived on the ground within those communities to be able to identify what was needed. Next one, Julie. So we listened and we heard the stories. We acknowledged the Māori-led solutions that were being developed across our communities. We advocated for and we funded iwi, hapu, Māori initiatives that were going to support our people in that COVID time. We used Māori models of practice for health, mental health, and addiction-related support requirements that were needed. We built authentic relationships across the community, within councils, across the health and well-being systems, with the police, and we shared resources, and we didn't maintain control of that. We wanted to be assured that our community was safe. And we enabled the decision-making for those most affected to be able to hear their voice to be heard. And we challenged inequity. Everyone was, whoever needed support, were able to access that in a timely manner. Next one, Julie. Bye-bye. So I can't emphasize enough throughout this pandemic journey that the Indigenous models that we initiated were hugely effective. It's interesting that the model that was initiated at this time in COVID has also been used most recently in some of the floods that we've had in Aotearoa, New Zealand, where iwi groups have rallied around, they've pulled the resources together, and some of us have travelled to those areas where the crisis is to be able to offer support. But our iwi-led responses have been faster, and certainly from our experience with COVID, more trusted and responsive in supporting the systems. And Māori health equity across that environment has been, we've seen a far more equitable approach in that regard. Next one. I think it's nearly the last one. Is that what the last one, Julie? And I just wanted to share a story before I finish that one of the experiences I had as being part of the emergency ops unit was it was Christmas Day, the first year of COVID after lockdown, and I got this call from one of the public health physicians who said, Philly, we've had an experience in a community, a Māori community, where the public health physician went to visit some of those people who were isolating on this house site in a caravan, and there was a big party in the garage having a Christmas celebration, and they were all from a local gang. And as this person was there, they witnessed the babies who had COVID coming out of the van and being told by one of the uncles, you get back into that thing, otherwise I'll throw you over the fence, supposedly quite aggressively. This public physician wanted to ring me to say, I think we need to get social services to remove those children. I said, no, that's not what we'll be doing. We'll work with the people within that community to identify the best solution and helping everyone understand what's happening. It's Christmas. We're likely to come across people drinking alcohol and drugging and all sorts of things, but we have to be respectful about the process and know who and what's happening. So what we did was we identified a leader in that community. We said to him, can you go around to the house and see what's going on? He went, and they all dispersed. The party dispersed. They all went home after having kissed all of the people that had COVID in the van. They'd acknowledged them. They wished them all Merry Christmas. Merry Christmas. So as you can well appreciate, one of the things that we had to do thereafter was go and screen all of that community because they were exposed to COVID. But I can't say enough for how incredible the Māori response was in this time, particularly in my community, and how the leaders stood up to make sure that our people were safe. The mental health and well-being of our people were protected because people understood what it was that they were looking for and how they could support and be, be available for people to be well. I think that's me, Julie. There might not be another one. Oh, yep. So last one, in honouring the work and wisdom of our people, I acknowledge where I come from and the people of this place. And I honour those that we've lost who and those who protected our communities, and reinforce that culture is not just identity, it's a pathway to resilience and recovery. Kia ora. Thank you.
Thank you, Phyllis, for the touching video. And it was amazing how you thought of people at risk and provided care beyond the clinical, because we get so stuck in the clinical. If anyone has any questions, please put them in the chat box and we will get to it later. Moving on and keeping in with our time. Next up, we have a performance piece, and we have the privilege of listening to a track by Macy Rika of Aotearoa, New Zealand. Macy Rika is New Zealand's multi-award-winning Maori singer-songwriter. She has one of Aotearoa's most impressive lead vocal styles, fused with her honest and thought-invoking messages. Hailing from the serene shores of the east coast of the North Island, Macy's music has molded to bring elegance that resonates beauty. A mix of Maori, folk, acoustic, soul, and easy listening, her musical palette is vibrant with elements of roots and deep culture. Her songs are filled with touching tales and the universal emotions of hardship, happiness, love, justice, and sorrow we can all relate to. The ancestral sounds of traditional Maori instruments are used alongside energetic guitars, drums, animated horn sections, and pure string sections. Macy has toured the world, sharing her music, her Maori culture, and stories with thousands of people in countries like Malaysia, Singapore, Taiwan, Japan, Indonesia, Australia, UK, Europe, and America and China. The track is titled Tangaroa Whakamote. Thank you.
Te arara o tamagoa, e
Thank you. That was a lovely piece from Macy. Next up, we are fortunate to have two presentations from individual country perspectives, and I am pleased to introduce the first presenter, Dr. Catherine Torote from Kiribati. Dr. Arite, or Kathy, is a psychiatry registrar from Kiribati. She is currently in her second year of the Master of Medicine in Psychiatry program at the Fiji National University. Dr. Kathy earned her Bachelor of Medicine and Bachelor of Surgery from Cuba in 2012 and began working at Temiria Mental Health Services in Kiribati in 2015. In 2018, she completed a postgraduate diploma in mental health at FNU, then spent 6 years working in mental health back home in Kiribati. In 2024, Dr. Kathy returned to Fiji to begin her master's training. Dr. Kathy aims to improve mental health services and increase awareness among the people of Kiribati. Dr. Kathy will be speaking on mental health challenges Kiribati context. And secondly, I would like to introduce Dr. Sulia Asikia from Tonga. Dr. Sulia graduated in 2018 with a Bachelor of Medicine and Bachelor of Surgery degree from the Fiji National University. She worked as a medical officer in Tonga for 3 years, then joined psychiatry for the past 4 years. Dr. Sulia is also in her second year of pursuing Masters in Psychiatry from the Fiji National University. She also works at St. Giles Hospital as a psychiatric registrar, and Dr. Sulia will be speaking on mental health challenges in Tonga after Dr. Kathy. Thank you so much.
Melody, Mula, and warm greetings to you all. Thank you, Dr. Shital, for that lovely introduction. I also want to thank the organizers for giving me this opportunity to speak today. So it's a real honor to share about mental health in Kiribati, our challenges, progress, and the unique context we work in. So my topic is mental health challenges in Kiribati context. And I'd like to start by giving you a quick overview of our country. So Kiribati is a small island nation in the Central Pacific made up of 33 atolls and reef islands, while our land area is just 820 square kilometers. Our ocean territory is vast, over 3.5 million square kilometers. So by 2025, our population is expected to reach about 136,545, with half living in South Tarawa. We also face serious climate challenges, and as you can see the picture below, you'll see the rising sea level that has affected the Beso maternity ward. And this is just one example of how environmental issues impact our health systems, including mental health. So these challenges shape the way we deliver care and support our communities. So in 1980s was when formal services were first introduced. This marked a shift from relying solely on traditional healing to establish structured care. So Temeria Ward Services, which is our current mental health facility, was established in Tarawa. So the photo on top here shows the ward as it stands today. It's still the only dedicated mental health unit in the country. Development was supported by overseas consultants, psychologists, and volunteer nurses. And so in the photo here, you'll see some of our international team who helped build our services. They provided training, mentorship, and technical support. And their contributions were vital in shaping the early foundation of mental health care in Kiribati and supporting our local staff. So later, WHO in MHCAP program was introduced, and this helped train non-specialist health workers to recognize and manage mental health conditions, especially important in our country with very few specialists. Before all this, in 1977, the first mental health legislation was enacted, but with support from WHO and regional partners, it laid the foundation for protecting patients' rights and guiding care. So today, the legislation is under review, and it's being adapted into the Kiribati Mental Health Act, shaped to fit our local context and cultural setting. So this is a vital step forward in making mental health care more relevant and effective for our communities. So let me walk you through some of our key challenges that we face in mental health across Kiribati. So first, there's a low public awareness. Mental health is still poorly understood in many communities, and people often don't know where to go for help. Stigma and discrimination are strong. Cultural beliefs discourage open discussion, and many people feel ashamed to seek help. And families often seek help when symptoms get worse. So early intervention is rare, and by the time they reach our formal services, the situation is usually severe. Traditional healing is usually the first step. In our culture, when someone shows signs of mental illness, many believe they're possessed by a spirit or affected by witchcraft. So families often turn to a Christian pastor to pray over the person, or to someone in the community who practices traditional rituals to go against the spirit. These practices are deeply respected, but they delay access to medical care and put more pressure on our limited services. Geographic barriers make access difficult. Kiribati has 16 inhabited islands scattered across a vast ocean, and travel to the capital, Tarawa, can take up a full day by boat, and flights depend on limited schedules. And this makes it hard for people in remote areas to reach mental health services when they need them. So these challenges show why we need more awareness, better access, and stronger support system across the island. Let me go through some of the key gaps we face in mental health services. So we have no registered psychologist and only one psychiatry registrar currently working in Kiribati, as I'm on study leave. And this shows how limited our specialist workforce is. For most frontline staff, especially nurses and orderlies, they haven't had mental health specific training. Only 2 nurses have received formal training, and this is mostly in Tarawa. In the outer island, staff often don't have the skills to manage mental health cases, so they need to refer and discuss cases with the doctors in the main island. And for our, so apologies for that. So for the infrastructure, the media service often operates at a full capacity. Discharging patients to outer islands is difficult, and once someone leaves, the ward fills up again quickly. Now, police support is poor. The role in mental health cases are unclearly defined, and the Mental Health Act is still under review. Because police often say escorting patient isn't their job, and they think it's the hospital's responsibility. So they usually decline our calls unless someone is physically hurt. Now, ways forward. So, the Mental Health Act is under review, and this is a big step forward, and it will help clarify roles, improve patients' rights, and guide how we respond to mental health cases across Kiribati. We have postgraduate training to staff that have been referred to FNU. And we also have in-country training. And we thank New Zealand through Countess Mandikau, who helped us develop this case book, which is Kiribati Safe Practice Effective Communication. And this session where the staff learn breakaway techniques and teamwork. And this training helps staff stay safe while managing challenging patients. And they also protect the patients. So building local capacity is key to improving our mental health services. We've made some progress in mental health services through awareness, infrastructure, and access. So under awareness activities, we've observed the World Suicide Prevention Day and World Mental Health Day, and these events help promote public understanding and reduce stigma. So in the photo, you'll see WHO and DFAT teams joining our World Mental Health Day celebrations. And we have the patients in the yellow t-shirt and the green lava lava, which they all join in that celebration. And it's a powerful moment of unity and support. And for infrastructure support, we've renovated the KTM Wellness Center outpatient clinic and built a new men's acute ward in the photo on top. And we have DFAT who actually funded the building. And so we've also received boardroom equipments to support in-house trainings and meetings, which help us build staff capacity. We've also improved access through the launch of the 196 free line, which enables everyone from the outer island and all of Kiribati to reach mental health services directly. And Vodafone gave us that line where everyone can just call the services whenever they need to. So that is the end of my presentation, and I believe we have learned the challenges we face in Kiribati and the steps we're taking to improve through training, awareness, infrastructure, and support. Thank you all for your time and for listening. Wishing you all te mauri, te rai, te tapumua, kamrapa.
Thank you, Dr. Kathy, for that wonderful presentation. Next up, we have Dr. Celia.
Thank you, Dr. Shita. I hope everyone can be able to see my slides.
Yes, Dr. Celia, good to go.
Okay. Good morning, everyone. Hope all is well. And thank you, Dr. Shital, again for that wonderful introduction. So, obviously, I'm very young in the field of psychiatry, but I have been a Tongan all my life, so I will try to talk on mental health in Tonga, zooming in on the cultural wisdom and the challenges that we faced in Tonga. So Tonga is actually a small island in the Pacific of about 100,000 people. We have 3 main islands, 1 main island and 3 other small islands, and 70% of the people live on the main island, which make it easier to serve the majority. It's one of the last constitutional monarchy in the Pacific, basically saying we have a set of constitutions, a king, nobles, and the commoners. Tonga is known as the Friendly Island by Captain Cook, and I really believe it's because of the connective and the cultural living of the people that make him call Tonga the Friendly Island. So what does it mean to be a Tongan? Here is the seal of Tonga. You can actually tell from there the treasures and the core values of a Tongan community. In the center, you see the cross signifying the faith, the Christian faith. The leadership role is the crown, signifying the monarchy. And around the crown, you can actually see the 2 olive leaves. It actually talk about the government and the church, basically saying our culture and our faith. Zooming into the culture, we have the 4 golden pillars that actually define a Tongan person. You have to be very respectful and obedient to your elders. You have to be humble enough to know that you can actually survive on your own. You need others. And basically consider everyone else. Can't be selfish. And since our first king, the 19th century, Tonga has been declared a Christian nation, and he dedicated Tonga to God. So in his motto at the seal, you can see that he said, God and Tonga are my inheritance. But because of this as well, we realized that mental illness have a deep-rooted stigma. From the cultural point of view, mental illness is actually regarded or viewed as a weakness or a laziness. And in the religion kind of view, mental illness is viewed as a divine punishment or a work of the evil spirit. So with that in mind, let me take you through the current mental health services in Tonga. So in Tonga, we do have a facility. It's actually located on the main island. We have an inpatient team, about 4 doctors, team of nurses, psychiatric assistants. We also have a community team as well. We're operating under the Mental Health Act. And once a week, we have a mental health review tribunal where we have the judge and other bodies come together and look at our involuntary admissions. We operate with this for years now. So the services we provide, of course, we do some awareness, TV program, workshop, fun stuff like mental health days and suicide days. Inpatient services, outpatient services. So we have follow-up mental health clinic available from Monday to Friday, and then we have walk-in consultations as well. When we discharge patient, we send them home under medication on wheels. This is a team that actually go to the patient's home and observe them taking the medication, see how they interact in the community, and report back to the team. And when we discharge patient out of the main island, we work together with the doctor's bedside. Once or twice a year, we do workshops on the islands. So main challenges over the years. Well, I've been working for just a very short time, but we have realized there is rise in substance use disorders. There's also increase in the number of revolving door patients coming to the ward. And another thing we noticed, some family, just due to misunderstanding and things like that, they start leaving some of their patients, their long stays in the ward. And stigma has always been a challenge in Tonga because it caused things like late presentation, like Dr. Gethy said. Tonga is just like any other Pacific island. We face natural disasters, especially cyclones. But in 2023, we were hit with a triple disaster. And we realized we weren't ready. So the volcanic eruption, the tsunami, and the COVID-19 all happened in 1 month. So this is when we realized we didn't have any training in place. We didn't have human resources. We didn't even have protocol or guideline to actually follow. But still, we were able to help the communities. And with this as well, I want to talk about or zoom into the cultural strength and resilience and actually how they came together and help us throughout these challenges. So first thing first, let me talk about the Nofo Akainga. It's basically describing the Tongan way of living. It describes how an individual or a family relate to each other, how to act, how to behave. It's a way of expressing love and respect, and that's how we've been sharing our griefs and withstand hardships. So in the family or nuclear level, for example, the father is the protector and the mom is the nurturer of the children. Zooming out from the nuclear family comes to the relatives or nofo akainga. It's basically the communal kind of living. So for example, if we have a funeral, we already know which person will be the spokesperson and do the decision making. So it's usually your father's father or your father's elder brother. It goes in that lineage. We already know which family going to do the cooking, or which one will come with the tapa, or which one will come with the root crops. And you have to understand it has to be an expression of love and shared responsibility instead of implications. So with these values, it makes it easier and it takes the grief off the person as well. And then zooming out from the relatives, Nofo Akainga, to the village, we already have authorities in place. So these authorities, you have the chief, the pastor, or the preacher, and the government officials as well. So this is where I was able to witness how community resilience comes together, because when when the tsunami happened, it wiped off 3 small islands. And I was able to actually go to that islands. So there were only 2 boats that were able to go to the islands. And I went in the first boat. And together with me were government officials. We do screening, we do everything there. We were the national emergency, the health team, the police team, all of us were there. We were able to actually talk with the community, and we do meetings and health awareness and things like that. But somehow we noticed that there was a disconnection between the officials and the villages. Lucky for us, the second boat arrived there were two main authority figure that came in that boat. The first one was the spokesperson for the Crown Prince, and the second was a vice president of one of our main churches, and they were originally from this village that destroyed by the tsunami. So what I realized is that when they came to the village, they were already commanding respect when they were there. They knew what to say, they know what to say, they know the places to go. So out of the blue, we weren't calling meetings for the people to come to us. We went and sit at the community hall and share stories around the kava boat. We sing songs and tell stories and tell jokes. And out of the blue, we were able to actually talk about mental health, checking on stress, talk about grounding techniques and relaxation techniques. And what I realized is that these people have actually accept us into the community as one of their own. So it happened after working together with the structure or authority that was already in place in the community. Zooming out of the village setting, I was able to realize that there were overwhelming donations. Just because you grew up in this kind of connective living, you already know what to do when these things happen. So the donation were overwhelming. And this is the first time I realized that I do have other brothers and sisters in the mental health department outside of Tonga, because when the PMA team came to help the people, they were all Tongans, and they were psychologists, psychiatrists, nurses, mental health nurses. And it was so amazing to actually see how the community actually comes together and build resilience and actually survive this hardship. So with that in mind, we understand that we have limitations and we lack resources, we lack community involvement, and we don't have a rehab center, of course. But we're trying to utilize our resources. We're pushing training and research to actually happen. We're trying to empower our cultural system, the ones that's already in place. We are doing that now by trying to involve the community. So we don't just tokenize mental illness like dementia. We don't just tokenize it and introduce it to the community. We actually go and sit with the community and tell us what they want it to be called and how we can actually help them as well. So we've been doing community outreach and program like that. We also have been done training. So this is a safety training. We've been trying to do mental health care training with the help of USAID and WHO, of course. Thank you. So our way forward, and with the same spirit, I'm doing research in place. I'm trying to look for the factors associated with the revolving door patients at Viola Hospital, and I'll just compare the revolving door patients and the non-revolving door patients in terms of demographic factors and medication factors, community factors. Well, I'll be trying to see if community involvement is what we need. We might actually try to invest more resources there and put our energy into better use. And I think that's it. That's my short talk. Thank you so much.
Thank you so much, Dr. Celia, for that. Dr. Arithe, thank you. You highlighted important aspects of low public awareness and how you're overcoming them, and Dr. Celia for pointing out challenges you face and how you are tackling that. Do have one question in the chat. Phyllis, if you're still here, from Soro, you mentioned Manakitanga as an important value. What are some other Maori traditional values and/or principles that are essential in e-village responses? Thank you.
Oh my gosh, where do I begin? We need a whole wānanga over several days to go through them. I mean, certainly in terms of supporting our whānau with mental health and addiction-related issues, there's manaakitanga, there's aroha ki te tangata, or the love and reciprocation support that we give to one another, that's aroha. Manaaki. Whanaungatanga is the relationship and how important that relationship is, establishing either on a one-on-one basis or between family members and the wider community. So relationships are hugely important. Just a few, but I'm happy to send some out as an attachment because there's just so much more that's an integral part of who we are. Yeah.
Yes, please. Thank you so much for that, Phyllis. That was amazing. We have time for one more question, very briefly, Dr. Celia from Soro. Is there a clash in world views around the stigma of mental health and trying to action culturally responsive approaches, especially on maintaining privacy and confidentiality? From
Thank you so
Soro.
much for the question. But yes, we're trying to actually be more tactic about that, because when we come to the community setting, it's all about, sitting and talking, telling stories. But we also try to educate them, especially the authorities, like the town officers, anyone in the community, that they are able to actually trust to actually go. We have a pathway in place where they can actually go and they reach out to us privately in the ward, and we can actually sort out the confidentiality and things like that in that space. Thank you. I hope I'm answering the question. Thank you.
Thank you, Dr. Celia. We have one comment from Altaf. He suggests for HR practitioners across the country to include these aspects into workplace practices and as they're vital. So thank you so much, everyone, for joining in. And thank you to all our presenters for your valuable insights into the mental health challenges and the opportunities for people living in the Pacific region. The World Health Organization's regional framework for the future of mental health in the Western Pacific from 2023 to 2030 is a response to the growing burden of mental health conditions in the region, the significant treatment gaps, and the exacerbation of mental health challenges by the COVID-19 pandemic. It provides a regional roadmap and key directions for the region that aligns with the global sustainable developmental goals and is informed by consultations with experts and member states. The framework's aim is to help member states strengthen their mental health systems by integrating mental health into daily life and primary care, by promoting leadership, mobilizing resources, and fostering community-based support for well-being and mental health conditions. There are three key strategies. The first is the need to refocus the mental health, the mental health agenda through advocacy and leadership, whilst including mental health in all policies and strategic communications. The aim is to reach people who are currently not receiving help to reduce stigma and discrimination. The second strategy is to transform mental health support and care into community-based and social service ecosystems. And thirdly, we need to embed mental health into all community settings and daily life. As a global community, it is essential we support each other, recognize the strength of individuals, communities, and nations, protect cultural diversity, boost mental health awareness and individual health outcomes, and ensure access to quality mental health care services are available where and when people need them. Thank you for everyone. Thank you to everyone for attending this interesting webinar. I would also like to thank the small but hardworking groups of the Oceania Mental Health Webinar Working Group. We are Michelle Ramsey, Natalie Cutler, Connie Gann, Julie Millard, Peter Gianfrancesco, and myself. The recording of this webinar will be put on the World Federation for Mental Health website soon. And to remember, World Mental Health Day is this Friday, 10th of October. It's a program of the World Federation for Mental Health. Every year, members of the Federation raise awareness globally about the mental health challenges for individuals and communities, about areas needing focus, and the service and funding gaps. This is through a loud and unified voice needed now more than ever. The theme for this year is access to services, mental health in catastrophes and emergencies. The 2025 World Mental Health Day campaign toolkit is available at our website, as shown there. And if you have any questions or any comments, please feel free to send it to the presenters. And we would like to say thank you, Kam Rabua, Namihi, Malo, Papate, and Vinaka Vakelevu for attending our webinar. Take care and be safe.